Can you hear me? All right, everybody, let's go ahead and get this thing rolling. Are there? Okay. Yeah, if the Zoom people can't hear me, please let me know. Hey, everybody, I'm Kyle. We're going to get started now. If I could get some chatter down. Okay, that always happens. Okay, everybody. Well, today's speaker is going to be Sam Wilkinson. I'm glad everybody is excited and full of energy. So Sam is currently the associate professor of psychiatry at Yale School of Medicine, where he also serves as associate director of the Yale Depression Research Program. Sam got his bachelor's from BYU, Brigham Young University, in 2008 in mechanical engineering, and then went on to earn his MD at Hopkins in 2012, and then completed his residency and fellowship at Yale in 16 and 17 and the Department of Psychiatry, and then went on to join the faculty at Yale School of Medicine after his postgraduate medical training, and then was promoted to associate professor in 2023. He's been associate director of the Yale Depression Research Program since 2020, and he has been a board certified psychiatrist since 2016. And at the research level, Sam is a leading expert on improving access to and dissemination of preventative measures and evidence-based therapies for depression and suicide prevention with tools such as electroconvulsive therapy, ECT, ketamine, and cognitive behavioral therapy. He has an impressive bibliography. It contains over 100 publications, including as first or senior author in journals such as New England Journal of Medicine, American Journal of Psychiatry, JAMA Psychiatry, Molecular Psychiatry, and PNAS. I could go on and on there. He's been funded for quite some time from NIMH, from NIDA, the BBRF for Brain Behavioral Research Foundation, which was formerly called NARSAB, and the American Foundation for Suicide Prevention. He is currently PI on 2 R01s that are funded by NIMH, and then as MPI on an R21 from NIDA. He's received many awards, many honors during his career. I could go on and on. Some of those are from NARSAD as well as New England Journal of Medicine, and then also received travel awards from highly competitive ACMP travel award, which I've learned more and more about how competitive that is in my training, and then the American Foundation for Suicide Prevention. Importantly, he's actively engaged in professional service at many levels, including as a member of the editorial board of several journals, such as Journal of Clinical Psychiatry, which he's served on since 2022. But most importantly for me, he mentors many early career clinical and preclinical researchers, including at the American Society of Clinical Psychopharmacology, which is where I was fortunate to be paired with him as a mentee back in May in their meeting in Miami. So he cumulatively serves as an excellent example of a scientist who conducts innovative research to help folks get well. And his talk today is entitled, as you can see here, Novel Therapeutics in Depression, Ketamine, Esketamine, and Psychedelics. And so please help me welcome Sam.
Thank you, Kyle, for that generous introduction. I told my 11-year-old son that I was coming down to Baltimore to give a very important talk. And of course, the first thing he says was, well, why are you giving this talk? You're not very important. And then being the brave father that I am, I proceeded, even despite that initial feedback, I proceeded to ask if he had any advice. So here's his advice. He said, Dad, be brief, don't drone on. Be dramatic, but not too dramatic, and most importantly, skip the boring parts. So I will endeavor to follow that sage advice from my precocious 11-year-old. I'm excited to talk to you today about some of the work that our group has been doing, as well as work from other groups. It really is an interesting time in not just depression, but in psychiatry. We're finally getting truly novel therapeutics. We're getting out of the just the monoamine deficiency hypothesis for depression and other disorders. I imagine many of you saw the the novel therapeutic approved for schizophrenia about a month ago. It is an exciting time, despite the fact that there are challenges. Here are my disclosures. Let's see, does this work? Yes. I get funding from a variety of sources, some of which is for-profit. That is administered through Yale University for the conduct of clinical trials. I'll note that Yale has an institutional conflict of interest for esketamine. They own part of the patent. I haven't worked with Janssen in a number of years. That's the maker of esketamine. Here's a brief agenda. I want to talk about basics, background, a brief update of evidence, and I'll spend a lot of time talking about ketamine and esketamine. That's where I've done a lot of my work. And then I want to give a little bit of a teaser for psychedelics. It's a very interesting area. There's a lot of interest in that, and so if I have time, I'll get into that as well. Let me start with just a timeline, a little bit of history about ketamine. So back in the 1950s, there was a company that was trying to develop a new anesthesia medicine, and what they came up with was phencyclidine, known as PCP, or on the street it's known as angel dust. And they quickly realized this wasn't going to work as an anesthesia medicine. It left patients in a difficult behavioral state, and so they went back to the drawing board. They reduced the potency at the NMDA receptor, and they came up with ketamine. Okay, and ketamine was successful as an anesthesia medicine. And around this time, what was going on was the Vietnam War. And unlike a lot of anesthesia medicines, ketamine does not generally reduce blood pressure or heart rate. And so it's a safe anesthesia medicine to administer outside of the hospital, where monitoring and so forth is not available. Because of the Vietnam War and this property of ketamine, it quickly became fairly popular as an anesthesia medicine. It was formally approved in 1970. Back in those days, you could use things before they were FDA approved, and I wasn't around then, and not sure how that worked, but about 15 years later, it was added to the list of essential medicines of the World Health Organization. Kind of along this time, there was some work by Phil Skolnick and others in neuroscience looking at not necessarily ketamine, but this idea that NMDA receptor antagonism may provide a novel mechanism for antidepressants. Going back to ketamine, despite the unusual and largely beneficial properties of it as an anesthesia medicine, there was discovery that it also had abuse potential. And it was designated a class 3 medicine by the DEA in 1999. And shortly thereafter, it was really the first report that the low doses of ketamine, sub-anesthetic levels of ketamine, could produce rapid and profound antidepressant action. That was done at the VA that is associated with Yale. This was replicated by a group at NIH in 2006. And all this while, the World Health Organization is kind of reevaluating the risks and benefits of ketamine. There was a consensus statement that came out from a group sanctioned by the American Psychiatric Association in 2017 about the use of ketamine in depression. It's not FDA approved for this. And then it was during the 2010s is when a company, Janssen, took not ketamine, but esketamine, one of the enantiomers of ketamine, and developed it for treatment-resistant depression and depression with suicidal ideation. So the FDA approval was granted in 2019, and then for depression with suicidal ideation a year later. And of course, the mechanism, I know for those of you who may not be aware, the original kind of traditional mechanism that is attributed to ketamine is NMDA receptor antagonism. There's been a lot of work since then, and particularly by Todd and others, about how, well, maybe it's not that simple, and nothing really ever is in psychiatry. So the mechanism, like the mechanism of pretty much everything, is still an open question in psychiatry. So let me tell you just a little bit of the basics about esketamine. I'm sure there's a number of people who are not familiar. Again, esketamine does have FDA approval for depression. The way it's done, it's a treatment that is done in the office. It's not a medicine that you take like a pill, like Prozac or anything. The first month is twice per week. Then if it's helpful, you'll treat patients once a week for another month, and then you spread to maintenance. The key side effects, dissociation is not a great word, but that's often the one that's used. That lasts about an hour, and patients have to be monitored and in the clinic during this time. Headache is pretty common, nausea is pretty common, and then this bad taste, probably because of the medicine, it drips down the back of people's throat. Just a little bit about high-level esketamine. It is subject to a very strict drug safety program that is imposed by the FDA. This is called a REMS. As I mentioned, the treatment has to be done at a clinic, not at home. You can't drive on treatment days. Patients have to be enrolled in a registry, and there's a lot of paperwork for clinics. So again, here's what the phases of treatment kind of look like. After that first index course, that month of treatment, the label and the evidence, or rather the label, it doesn't give a kind of a stopping point. It's, treat indefinitely every 1 to 2 weeks during maintenance. It's a little bit controversial. So let me share a few of the latest studies that we're trying to figure out where this falls in the context of our treatment algorithms. And for the beginning, I'm going to use esketamine and ketamine interchangeably. They are definitely different, and there's some lack of clarity as to whether there is a meaningful difference between the two of them. But we were part of a study, a large multi-center study that was called the ELECT-D study that finished up about a year ago, maybe a little more, in which ketamine was compared directly to ECT. Now, ECT, electroconvulsive therapy, it's kind of been the gold standard for difficult to treat depression for a number of decades. And this was one of two kind of large studies that directly compared these therapies. So in our study, the ELECT-D, there was 400 patients randomized for 5 clinical sites. Most of the patients were outpatients at the time that they started the trial. There was evidence of what's called differential dropout, which is not good in a trial. There seemed to be a higher preference for ketamine because people, once they were randomized to ECT, were more likely to drop out before they started treatment. I can't say this officially, but overall, if you look at the graph, ketamine did better. This was formally what's called a non-inferiority trial, where the real question you were asking is ketamine as good as ECT? The way the statistics work, we couldn't actually say that is ketamine better, but that's what it looked like. And then it did much better in all the cognitive outcomes. Among the inpatients, of which, again, there was a small sliver, maybe ECT was as good or maybe a bit better for ketamine. Here's kind of the raw data. So the top left panel, you see the response rate, okay? So you had about 55% response rate in ketamine group and something like 40% in the ECT group. And then response rate in the panel on the top right by another measure, more or less the same pattern. And then you see the continuous outcomes on the bottom left and the bottom right. These are both measures of depression. The lower you get on the graph, the better it is. So people start out, high, and then they get better. And the ketamine group, you see, gets a little bit lower than the ECT group. So that was an important study. Gave us a sense that for kind of moderate to somewhat severe depression, ketamine could do as well, at least in the United States. While that trial was going on, another trial that was done in Europe basically tried to ask the same question, randomizing people to ketamine or ECT. And they came up with a somewhat different answer. This is the continuous outcome measure, the depression severity, again, going low is better. So people start out high, and then you see a difference. And in this group, in this study rather, ECT did better. So we're trying to figure out what is the difference? Why did we get these kind of different outcomes from trials that were essentially trying to ask the same question? Well, one of the factors is that all the patients in this study were inpatient. A lot of this also had to do with the expertise of the sites. So all these sites in this European study, none of them really had much experience with ketamine, whereas pretty much all the sites in the US, most of them had pretty extensive experience with ketamine. That makes a difference. When this study tried to look at different subgroups among patients, you'll see the remission rate between the two groups, just all comers. It was definitely higher among ECT than ketamine. And when we look at age and the presence or absence of psychosis with depression, so the young people didn't really seem to be a difference, but the old people, they definitely did better with ECT. You see a 77% remission rate versus a 37% with ketamine. And then it's not significant because the samples are pretty small, but it does lean towards, you see almost 80% of psychotic depression patients remit with ECT compared to half the patients with ketamine. So in the US study that I was a part of, electee, we didn't have psychotic depression. That was part of the exclusion criteria. So the takeaway here for practicing clinicians, at least my takeaway, if you have inpatients, probably want to think about ECT. If you have older patients, probably want to think about ECT. Psychotic depression, probably want to think about ECT. The strong history of substance use disorder. Now, this doesn't come from the trial data. This is kind of our practice patterns up at Yale. Probably want to think about ECT. All others probably make sense to try ketamine first. Now, again, there's a lot more nuance in the way that the practice is carried out, but these are some of the kind of the moderators that I think about when I see a patient who's maybe on the fence doing one of these treatments versus the other. Another big trial of esketamine versus quetiapine. This was also a European study. It was a large study, 670 patients. This was funded by the maker of esketamine. Again, I'm using kind of ketamine and esketamine interchangeably here, but esketamine versus quetiapine. The remission rates are kind of on the low end. This is treatment-resistant depression, but esketamine did better. 27% remission rate versus 17% for quetiapine. And then the same in terms of keeping well on the bottom panel, the proportion of patients that go without relapse for about 3/4 of the year. Here's the continuous outcome data. As you see, again, the lower you go on the scale, the better it is for patients. The esketamine group is lower, kind of across the board at these different time points. So this is a fairly long study for a randomized study. It's about 9 months. What about safety? So I think a year ago, there were headlines all over with Matthew Perry, if you recall, and I think he died in October, and then a report came out in December that kind of shocked me that ketamine had been a contributing cause to his death. Now, I was shocked in part because ketamine is very safe. Now, what seems to have happened here is that he took a whopping dose, and he was by his pool, and he fell into his pool and drowned because he was asleep. If he had taken that dose and he was in a doctor's office, he would have woken up, maybe an hour or so later. So, but this does, it does bring to mind, are we doing this the right way? Are the guardrails, the appropriate guardrails where they need to be? It was pretty clear in the articles that came out that there were, some bad actors here, not Matthew Perry, but the doctors who were essentially enabling his substance use disorder. He had developed the fondness for ketamine and was using more of it than he should have. A little bit before this, actually, there was a doctor who was sending ketamine to people's homes in like 45 different states, and the DEA shut this down. This is the first that I was aware that the government really intervened in a heavy-handed way to shut down clinics. Now there are tons of clinics that have kind of sprouted up all over the country. One of the things that is happening here is that some of these clinics will give patients take-home doses of ketamine. There's this kind of discrepancy because with esketamine, that is specifically not allowed by the FDA. But this, this was an interesting thing that happened. I guess it happened in May of 2023, so about 18 months ago. So I've been kind of using ketamine and esketamine interchangeably, but are there any differences? Let me go into this. And certainly there are, especially in logistical terms. I've alluded to some of them now. But one of the differences is that there's a lot of regulation for esketamine, but it's pretty loose with ketamine. Esketamine, as I think I've alluded to, is given intranasally as a spray. The most common route of administration for ketamine for depression is intravenous. There's also intramuscular and some other things, but most common is IV these days, at least as far as I can tell. Esketamine is FDA approved, whereas ketamine is not FDA approved, and because of that, again, you have this very strict drug safety program that goes along with esketamine. But it's kind of the I would say the Wild West with ketamine clinics. There's not a whole lot of oversight. And because of this, this uncertainty here, there's confusion among patients, families, third-party payers, the general public. This is one quote from one of the earlier ketamine clinics that started in New York. He says, "For the treatment of depression, PTSD, et cetera, IV ketamine is the gold standard. As such, we do not offer esketamine at our center." I would say there are a lot of opinions, but not a lot of great data. There are a few reports of secondary analyses of clinical data. So we've put out our clinical data. This is non-randomized. There are patients at our clinic, some of whom get esketamine, some of whom get IV ketamine. We did an analysis of about 200 patients. This was published maybe a year or so ago. And there weren't a whole lot of baseline differences, which is good, but it is still a huge caveat that this is not randomized. They had the same proportion of public versus private insurance. What we saw is maybe a hint of a signal suggesting that IV ketamine might be more effective, but I can't couch that enough and say that there's lots of caveats to that. The most important one is this was not randomized, and there very well could be unmeasured differences at baseline and different reasons that people got different treatments. The ratings also were not the highest of quality because they were done in clinical rather than research settings. And over the course of our study, at least, well, not a study, but over the course of our clinic, we started out with shorter courses of IV ketamine. Back in 2014, 2015, we were maybe only giving 2-4 treatments. And then as more data came available, we would give 8 treatments in an acute course. So the data is preliminary. It's not definitive. Is there a meaningful difference? Clinical efficacy? I would say that's unknown. Now, cost effectiveness, that's a tricky question because you always have to answer from what perspective. Certainly, Spravato costs more. Spravato is esketamine. Sorry, I should use esketamine. Esketamine costs more. New drugs almost always do. But to the patient, generally, esketamine is cheaper because it's more likely to be covered by insurance. Safety, I would say it's unclear. Cognitive outcomes are something that at least the FDA worries about. Some of us also worry about it. A lot of it depends on dose. In terms of the practical, real-world administration of this, I would say esketamine is safer because it's more regulated. There's not a whole lot of regulation of IV ketamine. Abuse liability, we don't know if there's a meaningful difference. Bladder issues, fortunately, there haven't been. One of the concerns with ketamine from the get-go has been that at really high doses, you can get irreversible bladder damage. It can be very, very painful, even having to result in reconstructive bladder surgery. At the esketamine doses that are FDA approved, we haven't seen that. So that's a good thing. Again, we don't know exactly what's going on with the ketamine clinics because they're not very well regulated. Something that happens when you give people ketamine or esketamine, every once in a while they'll have it looks almost like a panic attack where they feel very intensely anxious. Sometimes you just have to hold their hand. Other times you give a benzo. We call these dysphoric reactions. It's not clear whether there's a meaningful difference between these two treatments. in the likelihood of dysphoric reactions. I am excited to be a part of a large study that's getting underway. Actually, we hope to start our enrollment this month or next month. We're calling it the equivalence trial, where patients are randomized to either esketamine or ketamine. There's 6 sites that are participating in this, and we hope to enroll about 400 patients, and go over maybe 4 or so years to get our enrollment where it needs to be. There's 3 academic sites. These are them, and then there's 3 community sites that I think are very high quality community sites. Let me share just a little bit else about some of our work in trying to utilize what are somewhat unique properties of ketamine in that we think that it enhances cognitive plasticity, neuroplasticity in the short period of time after exposure. So I mentioned briefly that esketamine was approved by the FDA for the treatment of depression with suicidal ideation. The way this protocol was designed, I think it had a big flaw in that, unlike the protocol where you go into maintenance phase, that didn't exist in the studies that led to this indication. So patients had their 8 treatments and then they stopped. And if anyone knows anything about suicide risk, it's really, really high after you leave the hospital. And all the patients that went into the studies that led to this approval were hospitalized at the time they started treatment. So you have a hospitalized group, you give them this rapid acting treatment, and then it stops after 4 weeks. And then they're also recently left the hospital. To me, that sounds like a bit of a flaw in the way you design your protocol. So what we have done is we've tried to combine ketamine in prior studies, in a current study, esketamine, with cognitive behavioral therapy. Now, the thinking here, this is some pilot data we did a couple of years ago, where patients received ketamine plus CBT or just treatment as usual without CBT, and you see towards the couple months they start to separate, suggesting that CBT may have some enhancing effects. So the thinking here is that, at least traditionally, we have as we've gone beyond the monoamine deficiency hypothesis of depression, a lot of these disorders that we deal with are conceptualized as disorders of plasticity, right? The brain loses its ability to adapt to changing environment, and we apply a treatment. Let me use this pointer. So let's see. At this one, I see. Okay. I've never had that. Okay, so you have this disease state here, and then you apply some treatment, and there's an enhancement in plasticity. But if you discontinue the treatment, there's a regression and return to the disease state. Now, this is what we have termed the monomodal treatment approach. What we're trying to do here is intervene where, when there is a treatment that enhances plasticity, we try to intervene in ways that will kind of solidify or take advantage of that window of plasticity. When I talk about this to people outside of medicine, my family, I sometimes use this example. It's like wet cement. Okay, so a therapy is making the brain more wet, but you don't want it just to be wet and harden in some random way. You want to shape it so that when it hardens, it stays in the configuration that you want it. So with that in mind, we are wrapping up. We call it the Endure trial, or the CBT Endure trial, where patients are receiving esketamine and then they're randomized to receive CBT or treatment as usual. This is patients with depression with suicidal ideation, most of which, excuse me, not all of which, but most of which are hospitalized at the time of treatment. This is our study schematic. Again, patients, mostly they're hospitalized at the time. They receive their 4-week course of esketamine plus or minus CBT, depending on randomization, and then we follow them for a total of 6 months. The CBT starts after 2 weeks of esketamine. There's 3 centers that are participating in this. We're just really wrapping up our enrollment this month, and we hope to get our results by the middle of next year. Let's see. So let me talk a little bit about abuse liability, because this is an issue, and there is data that illicit ketamine use is going up. This was a paper that that I helped write with a colleague at NYU. He's very interested in this issue of ketamine use disorder. So this is the word, I don't like the word seizures here because it has a different meaning, but think of it as confiscation. So this is confiscations of ketamine, of illicit ketamine by the DEA over time. And as you can see, there are clearly trends in both the number of confiscations as well as the weight of the total weight of ketamine confiscations. So there's something going on as ketamine gets more popular as a treatment. You know, how much this is related to its medicalization, we don't know exactly, but there's something going on here. This is another paper from Joey looking at self-reported past year ketamine use, and particularly, you know, it cuts off around the time of the pandemic, but particularly from 2017 on, you see this, you know, this sharp uptick. We have to kind of, you know, redo these analysis with more data as it becomes available. But there is a worrisome trend that we need to be aware of. And there are also, you know, reports of people who have basically developed iatrogenic ketamine use disorder. Matthew Perry is one of them. That was all over the news. But one patient that we saw at Yale who came to the VA ER was basically using ketamine 3 or 4 times a day. It was prescribed to him. There was another patient that was written up about 10 years ago at Mayo. So there is, I think, a need to be careful here. I think one of the best ways we can guard against this is not to do home use of ketamine. Now, there's this tricky tension between safety and access. And a lot of people will say, well, you know, then you're going to limit the access that people who really need this treatment. There was a report that in the Psych Times that approximately 50% of those who are prescribed at-home ketamine don't use it properly, either accidentally or perhaps on purpose. So that is one issue I think we need to be aware of. From my standpoint, I think we need to be very, very careful about this at-home ketamine use prescribing. With esketamine, with the FDA-approved thing, that is specifically prohibited. But because of the kind of the loopholes in regulation that is technically allowed with ketamine. Let me shift a little bit and talk in the little time I have left about psychedelics. Okay, this is kind of all the rage. And many of you may have seen some of the headlines. There was a company that tried to develop and file for approval MDMA, which is colloquially known as ecstasy, as a therapy for post-traumatic stress disorder. Now, this happened over the summer. The FDA convened a panel, an advisory board. When the FDA is facing a difficult decision, they will sometimes convene an advisory board to help, you know, guide their thinking. So the advisory board met, I think, in June. They recommended rejecting this application, and then the FDA formally ruled on this, I think, in August, and did actually reject the application. Now, when a new medicine is up for potential approval, kind of the rule of thumb is there need to be 2 large pivotal trials that are positive, that have shown benefit and relative safety. And this happened with MDMA, excuse me. There were 2 positive phase 3 trials. So, you know, there's been a lot of discussion since. Why did the FDA say no? Why did the advisory board recommend rejecting MDMA? There were a number of issues. I'll just go through a couple of my thoughts about them. One of them has to do with this issue of unblinding. And this is not an issue that's unique to psychedelics, but it's particularly poignant in psychedelics. So the issue of unblinding is that you can figure out what treatment you got, especially if the control group is placebo and the active group is you know, MDMA or Psilocybin or something that takes you on this pretty intense trip for a couple of hours. There's going to be a lot of unblinding. Now, I don't want to be naive because there have been FDA-approved products and medicines where unblinding has occurred. Certainly with esketamine, unblinding was an issue. The thing here is that there's virtually 100% unblinding. So the question is, how much is okay? And we kind of need to come to some sort of answer as a field because there's an issue with these very, you know, psychoactive drugs. So that was one of the issues I think that was difficult for this company to overcome, and was a big weakness of their trials. Related to this, they enrolled, I think 40% of the patients they enrolled had previous MDMA exposure. That, from a trialist perspective, that's kind of a tricky thing. If you're developing a new medicine, if you're developing Prozac, something like that, and enrolling people who had prior exposure to it usually is not something that you do. But here they had 40% of people that had prior exposure. That, combined with the unblinding, I think was a key weakness. Another issue that has been brought to light is this issue of the drug psychotherapy combination. Now, the way that this company framed their MDMA application is that it's really not the MDMA, it's the psychotherapy. The MDMA is facilitating the psychotherapy, but it's this combination that's really important. And one of the issues is the psychotherapy wasn't super well defined. It was somewhat vague. And so some people have said, well, yeah, it was the fact that FDA does not regulate psychotherapy. That was the Achilles heel of this MDMA application. I think that's not exactly true. I think there's some truth to it, but there have been several other prior FDA approvals, the ones listed here, where it says explicitly in the label that these things are intended to be done alongside supportive care, psychotherapy, counseling, et cetera. Okay. But I think this is an open question. How do we think about, especially with therapies that we're trying to get FDA approval for, which will make for standardization and implementation, how do we think about combining drugs with therapy in a way that regulators will like and accept? That's an open question. Another issue was the integrity of the data. So unfortunately, I think there was a lot of hype around this. The patients in these trials reportedly were told that they were making history by being a part of this trial. That is not something you want to do as a trialist. There's this principle called equipoise, which basically means there's some uncertainty. We're not sure if this is the right thing. That's why we're doing the trial. You want to maintain some sort of equipoise, especially given all the unblinding that happened. So that's my postmortem of the MDMA failed application for PTSD. There's certainly a lot of promise, but I think we need to be very, very, very careful how this goes down, because I think there's lots of ways that it can go the wrong way. I will just note that the FDA is open to this, is open to labeling and approving psychedelics for psychiatric illness. They have published guidance for trialists as they design and conduct clinical trials. I'll just touch briefly about, sticking with the realm of depression, about psilocybin. So psilocybin, derived from, quote, magic mushrooms. There's been a lot of hype about that. There are two organizations that are trying to develop psilocybin for treatment-resistant depression. This is a paper from one of them. It's called Compass, and they published their paper, I guess it's been 2 years now. Man, time flies. So they had a phase 2 trial, which let's see, this, I think it was about 200 or so people. Yeah, it looks right, about 80 in each group, maybe 240 or so. They randomized people to one of 3 doses. 25 milligrams, that's a pretty hefty dose of psilocybin that'll put you out for a good 4 to 6 hours. 10 milligrams, and then 1 milligram is kind of like a homeopathic dose. So their primary endpoint, I believe, for this trial was the efficacy at 3 weeks, and they hit it. Again, this is a single dose. It's fairly impressive, I think, that you're seeing these effects several weeks after the one-time exposure. They have since started and are actively conducting 2 phase 3 trials to put together a complete package that they would then submit to the FDA for approval for psilocybin. The other organization that my clinic has worked with is called USONA, and they published a paper a little over a year ago, I think it was, in which they randomized 100 people to either psilocybin or high-dose niacin was the control. So you get high doses of niacin, you feel something. You have flushing and so forth. You feel something, but and that was done to try to help improve the blind. So this was a very positive trial as well. You see the separation between the active and the control. Their primary outcome was essentially 6 weeks, day 43. And again, I think it's pretty impressive that after a single dose, you get this, this effect that lasts for several weeks. So a lot of interesting stuff going on. Let me shift just a little bit and talk about what I think is another promising area, which is digital therapeutics. We recently participated in a trial of a digital therapeutic. Give a little bit of context. Essentially, what this is trying to teach people like psychotherapy skills through an app or through some computer-based program. We were a study. These are some colleagues of mine who are either alumni, faculty at Yale, or still there at Yale. This was a therapeutic that was derived to help reduce suicidal ideation and suicide risk. So I think the goal was to get around 350 patients to either be randomized to an experimental app versus just a quote sham app, which just teaches people about suicide risks. So patients were enrolled from a hospital setting. They were inpatient at the time that they were enrolled, and they either got the real app or they got a sham app. And the primary outcome was actually group difference in suicide behaviors, which is a pretty high bar. Most of the time, our outcome measures are scales like depression rating and so forth. So they were going to be followed for up to 2 years following discharge. This study completed recently. The data will be available hopefully in the next few months. But I think it was a neat trial in that it was looking at differences in suicide behaviors. There's not a lot of trials that do that because it's tricky. Let me just speak broadly about digital therapeutics and why I think we should be excited about them. This goes back to this issue of psychotherapy and how you combine them with drugs in a way that regulators like and can understand and it can be standardized. Up until recently, companies have had very little incentive to invest in psychotherapy research. Okay. By the way, the vast majority of research and development that happens in psychiatry comes from companies. Okay. This is the budget of companies versus NIH. Okay. And most of the company budget is for clinical trials. Most of the NIH budget is not for clinical trials. So there's a huge amount of funding here that for a long time, there's no way to get this funding and use it to develop psychotherapy, right? Drug research has received the vast majority of the funding compared to psychotherapy up until now. Now, digital therapeutics is not exactly psychotherapy, but it's psychotherapy-like that it teaches, is trying to help teach people to develop and use skills to ward off automatic negative thoughts that are so prevalent in depression and so forth. So I think this is a really exciting thing. This can help with a lot of other problems that psychotherapy faces, which is standardization and implementation and reimbursement and so forth. So I'm excited about digital therapeutics. As many of you know, I don't know the name of the company, but there was an app recently approved that they actually ran a trial and showed that it outperformed their sham app in depression. I think it's called Rejoin. I don't know the name of the company. I don't have any ties to it. But I think this is a good thing for patients. I'm excited about this kind of new stream of potential research where we can leverage psychotherapy principles and standardize them and implement them in ways that we haven't before. So I just want to thank all the people who, at least in my lab, have made this work possible. I also want to thank the people that in my life had made this work necessary for my kids. And I will take any questions. I don't think so.
Maybe now.
Yeah, sounds good.
So thank you so much for the talk. Amazing, very good. I think that I'd like to make one comment and one question.
Sure.
I think that one comment is about that work from the NYU where you show that there is an increase in the amount of the esketamine, the seizures and the numbers and the weight, right? But we don't have first it's clear that esketamine has abuse potential. So I want to say that, but we cannot be that get those conclusions from that graph, because first we have not other drugs. So because the what becomes in our mind is people started to being treated with ketamine or esketamine, and then they went and they used on the streets. Some people, they can think that, but first probably it's possible that other drugs increased even more, and then the focus was so for example fentanyl would be much larger than that, and other drugs as well. And the second thing, the different governments, they have different priorities. So if you change esketamine by illegal immigrants there, maybe the number will be much lower. So what I say is that from 2016 to 2020, there was a stronger focus on kind of those substances, but on apprehensions and seizures. So that's what I thought is kind of, we need to be careful with that conclusion. We are treating people, they're going to the streets and they are using it. That's a risk, but here in our clinic, we are extremely careful with that. We follow all the protocols. And yes, I've seen people doing that, not in our clinic, but just that's my comment. And the second part is, what do you think? Because we treat people with esketamine and ketamine, which are primarily glutamatergic medications, or they are believed to be. And then after we stop them, usually they go back to a monoaminergic antidepressant, right? So there is the Auvelity with dextromethorphan, that there is some action on NMDA antagonism, but actually it's highly criticized that this is kind of overestimated. And also on the esketamine trial, your opinion on Auvelity and esketamine trial with the oral medication that they argue that would be of lower abuse potential.
So the question, what do I think about Auvelity? Or
Yeah, so the use of glutamatergic oral medications to stop the need to go to the clinic.
yeah, so and just to give a little context, Auvelity was FDA approved maybe a year ago. Auvelity is a combination drug of dextromethorphan, which is a primary ingredient in Robitussin, and bupropion. So cough syrup for depression. I remember, excuse me, I remember being originally very skeptical of it. The data is pretty good. They ran those trials very well. I know one of the the lead guys for the program. He ran those trials very well. So the data is very good. What does it look like in the real world? There's almost always what they call it, an efficacy effectiveness gap, where things in the phase 3 trials look very, very good. You bring it to the clinic, it's not quite as effective. And part of that is because the phase 3 trials, they exclude people with lots of comorbidities, that sort of thing. It would be great if we could run a trial and everyone gets esketamine and half of them are randomized to Auvelity, half of them are randomized to placebo, and we see does the Auvelity help prevent the need for ongoing esketamine exposure. I think that'd be a great study. You should do it. That'd be. I think that would fill a critical need, right? So a lot of these places, ours included, one of the concerns is how do you get patients through and back to a reasonable either once a month maintenance or stopping esketamine, because it is very labor intensive. It's very inconvenient for patients, especially if they live far away. They can't drive. But I think that'd be a great study. I haven't used Auvelity personally as a prescriber, but the data look good from the trials. I remember being surprised, kind of impressed and surprised, like, oh, dextromethorphan. Who would have thought? So
Thanks.
Oh, yeah.
For a great talk. I
Yeah.
really enjoyed it. I guess I'll follow Gustavo's lead and have one comment and then a question related to dextromethorphan. I agree the clinical data looks very strong, but it looks to me very different than ketamine. You don't see
Sure.
rapidity of the effects, and I think that's due to the pharmacology. Where what I'd argue against is that it's acting through NMDA receptor inhibition, right? Because the molecule has much higher affinity for transporter than NMDA receptor, so you're probably getting a reuptake, especially when you're combining with bupropion. But then the question, and you commented in your talk briefly about ketamine being administered, or racemic ketamine being administered in different routes, so intravenous, intramuscular, subcutaneously, and orally. I'm just curious about your clinical impression and also your impression about the existing data about the routes of administration, how the route of administration may affect efficacy of racemic.
Yeah, that's a good, I don't have clinical experience beyond IV for racemic ketamine. IV is the only one that we've done at Yale. So I think a related question is how do we think about dosing with these kind of quote rapid acting antidepressants, right? So the historic, with traditional monoamine based drugs, it's like you get to a steady level, right? That's not how it is. At least in the original ketamine does. You get the single dose, you get a pulsatile dose. The body leaves the drug. Excuse me, the drug leaves the body a couple hours later. But yet there are these mechanisms, maybe mTOR mediated mechanisms that persist. And I think it's a more. I think attempts to try to provide a steady state. I actually think that's not a great idea for these types of drugs. I mean, for a variety of reasons, one of which is, a lot of these things will cause people to dissociate and that sort of thing. But for the efficacy as well, there can't put my finger at it, but there are reasons that lead me to believe that that's not going to be a good thing for efficacy to try to get a steady state of these, whether it's NMDA receptor, AMPA potentiators. And if I remember, I think some of the approaches of the subcutaneous is to try to make a more steady state level, and I would say that's probably not the right path. That's my opinion about it. So as much as the route of administration relates to whether it's pulsatile or steady state, that would be my answer.
Thank you for the presentation. I'm not a ketamine expert, so I'll ask a simpler question.
Sure.
I've been struck by how common daily cannabis use is, especially among young adults, but among patients generally seeking mental health treatment. And I wonder if you could comment on what your critical sense of eligibility criteria for clinical trials, like how we should be screening for cannabis use, how important that is, and then also any safety concerns you have about
Yeah,
using it with ketamine, esketamine.
This is a question that just is kind of like, it just comes back to us in our clinic. How do we think about these patients? I'm on the side of trying to be conservative. I don't love this, this proliferation in cannabis use. I think I've done other work in cannabis, and I think generally it's not a good thing for mental health. Probably most people who see patients would probably agree with that. We generally, at our clinic, have a policy of, okay, stop the cannabis. If someone can't stop it, then, that's an indication that they have a use disorder. And that's, one other thing to consider clinically. But we do kind of make exceptions, and treat things on a case by case basis. If there's some patient who, a patient a year or so ago, they were getting medical cannabis for migraine, and their neurologist, who was a good neurologist, swears that this was legit. They were doing this, and so we allowed that patient in. But if someone's doing it, like self-treating their depression, which I don't think is a great self-treatment, or using it recreationally, we will really say, we want you to cut down. But it's a vexing issue. I think someone over there. Maybe we got one more and then I can hang around. I don't know what my schedule is after this, but. Hello. Say it loud and I'll repeat the question.
I'm also not a ketamine expert. I'm a psychotherapist, and I guess I'm curious about the psychotherapy, or back in college, I would have called it trip sitting component. Have you seen this done? Have you seen effectiveness of that specific part of this process, or have you seen it done better or worse?
Yeah, so there's this issue. The question is about how does psychotherapy relate to ketamine? There's this phrase that I don't love. It's called ketamine assisted psychotherapy, and it's like all over. And what I think a lot of the ways it's done in the community, like outside of research protocols and stuff, is that while they're kind of recovering from their altered mental state, they'll be doing group or one-on-one therapy. I don't think that's a great time to do it. There's data that in that 1 or so hours after exposure, your cognition is impaired, right? You're kind of like, there seems to be maybe 12 to 24 hours after the exposure, a reverse of that, where cognition gets improved and, thinking, cognitive flexibility, whatever measures we're trying to get around this very tricky domain of cognition seem to improve compared to baseline, but that's not till like at least a few hours after. It's not while they're still here in clinic. While they're in clinic, they're impaired. So it doesn't make sense to me to do the therapy then. It makes sense to me to do the therapy like the next day or at the very earliest, later that day, once they've gone home, maybe can do a Zoom session. So.
I describe people literally holding someone's hand, though. Trip sitting happens during that week, not 12 hours later. That's component of like an RA in the room.
Yeah, that doesn't make sense to me. I mean, I know people do it. That seems to be definitely a thing in psychedelics, right? Where they say, we're going to make, what does this trip mean to you? What does this experience mean? We're going to make meaning out of it. Less so in ketamine. Ketamine is not nearly as intense as psilocybin and some of the other, quote unquote psychedelics. But I don't know of any good evidence that like finding meaning in the ketamine dissociative experience is is a moderator or a mediator of clinical efficacy.
All right, thank you, Sam, one more time.
Yeah.
Thinking about that a lot, primate response.